Hey everyone, welcome to Dump the Charge. We're going to break down anatomy, physiology, and pathophysiology, and we're going to make them relevant to paramedic practice. The aim is to try to help paramedics and paramedic students be able to apply this knowledge while they're out in the field dealing with these pre-hospital medical emergencies. Today, we're going to cover something that really should be bread and butter to paramedics and paramedic students, but it's something that often gets overlooked and a lot of the time forgotten as well. But we really should cover it and really should have it solidified in our minds, and that is the absolutely dreaded hemodynamic formulas, the formulas that explain blood pressure and cardiac output. These formulas are super important. They underpin how and why a patient will deteriorate either before you arrive or while in your care. And having a foundational understanding of them will help you to stay calm when this deterioration occurs and will help you to troubleshoot through the formulas to work out ways in which to adequately treat your patient and prevent deterioration, or to prepare for the potential deterioration that will occur and to understand how that patient will deteriorate. We can apply these formulas to pharmacology as well to help us understand the pharmacokinetics and dynamics of a lot of the drugs that we give quite regularly, such as nitrates, opioids, benzodiazepines. And they help us to understand the contraindications, the precautions, and a lot of the side effects that these drugs can present with. So before we move on to a lot of the theory behind these formulas, I'm going to present you guys with a couple of really simple patient presentations, a couple of really simple scenarios for you to consider as we walk through the formulas. And at the end of the video, we're going to revisit them and we're going to see how they apply and see if we can put them into action and put them into practice. Our first scenario is for a 55-year-old male who's called an ambulance for significant central chest pain that is persistent and is not self-resolving. On our arrival, as we walk in the door and lay eyes on the patient, before we even say a word, we notice that the patient is exceptionally pale and he's profusely sweating. He's diaphoretic. That's it. Our second scenario is for a 22-year-old male who is a stab wound victim. He's received a slashing injury that has resulted in an uncontrolled hemorrhage from his femoral artery. We've managed to stem the bleed with hemostatic dressings and compression. We've managed to load the patient, get him hemodynamically stable. We've bundled up the patient with a ton of blankets to ensure that he doesn't become hypothermic, and we're on our way to hospital. On our way to hospital, we look down at our monitor and we notice that the patient's heart rate, which was sitting at about the 100 beats per minute mark, has suddenly spiked to the 140 beats per minute mark. Okay, now that we've got the scenarios out of the way, let's go to the board. All right, so let's begin by actually writing these formulas out. The first formula is blood pressure equals cardiac output times peripheral vascular resistance. The second formula is cardiac output equals heart rate times stroke volume. Now I know these just look like a bunch of letters sitting on my page with a bunch of symbols sitting in between them, and they don't make a lot of sense right now, but don't stress. We're going to have a really good crack at breaking down each one of these concepts and understanding them and how they relate to each other. And when we do that, you'll have this bigger picture of how hemodynamics works. Let's start by defining stroke volume. Stroke volume refers to the actual volume of blood that is ejected by the ventricles in a single contraction, okay, in a single beat. As such, the units of stroke volume would be milliliters per beat, right? And it usually sits around that 50 to 100 mil mark, depending on the conditions that the body's spacing at any given moment. Taking a closer look at stroke volume, we see that there are three factors that actually influence the volume of blood that is ejected by the heart in a single beat. These three factors include preload, contractility, and afterload. I see you guys' faces now. I'm adding three more things to this formula. This is getting out of control. It's getting out of hand. What are you doing? Don't stress. We're going to break each one of these down really well as well, and we're going to relate them back to stroke volume and relate all of this back to hemodynamics at large, and it's going to make total sense. So just bear with me, okay? All right, so back to the board. Let's start with preload. Put simply, preload is the amount of blood that's returning back to the heart and filling up the ventricles during ventricular diastole. And this affects stroke volume in actually two different ways. The simplest way is that the more blood returning to the heart, the more blood there is to pump out of the heart, right? The higher the volume that enters the ventricles, the higher the volume there is to be ejected by the ventricle in that single beat, right? That makes sense. The second way is actually a little bit more nuanced and a little bit more interesting. One of the properties of the myocardium is its elasticity, right? And this plays a role here. Hopefully you guys are familiar with the Frank-Starling law, which basically states that the more the myocardium is stretched, the harder it'll recoil, right? So when we apply this to preload, the more blood that enters the ventricles during diastole, the more those ventricles will stretch with the weight of the blood. The The more it stretches, the harder it'll contract and the more blood it'll push out in that single beat, thus increasing stroke volume. Preload is highly dependent on our body's venous tone. If we have an increased tone in our venous system, what this means is that we have constriction of our veins. Now, what do veins do? Veins bring blood back to the heart. So if we constrict all those veins, what we're doing is we're increasing the amount of pressure with which the blood returns to the heart, which increases this thing called venous return. An increased venous return means increased ventricular filling, which will mean increased preload. Now, on the other hand, if we cause our venous system to dilate, such as when we give patient nitrates, for example, what we're doing is we are reducing that venous return and we're promoting a thing called venous pooling. This means that we have a reduction in our ventricular filling, which means we have a reduction in preload. Okay, let's move on to contractility. This one's a pretty straightforward one. The harder the heart contracts, the more blood it's going to push out in that single beat. There are several things that can influence myocardial contractility, one of which is preload, as we've already discussed, but there are several other things that can affect it as well. Primarily, the sympathetic nervous system has a bunch of nerve endings that will spread out through the myocardium and innervate the heart at the level of beta-1 receptors. And when it does so, it causes the myocardial cells to contract with more force and push more blood out in a single beat. Other factors that may influence myocardial contractility are things such as drug effects, such as when we see patients on calcium channel blockers, for example, or certain pathologies like hypertrophic cardiomyopathy, for example. Those are topics that are a little bit out of the scope of this current video, and we'll cover those in videos in the future, I'm sure. Alrighty, so let's move on to afterload. Afterload can be defined as the amount of pressure working backwards on the heart, which the ventricles have to overcome in order to propel blood forward through our circulation. Afterload is exerted on the heart by all of the blood that sits in the aorta and the pulmonary arteries, as well as gravity and things like the diameter of those blood vessels at the time of ventricular contraction. The higher the afterload on the heart, the higher the pressure that the ventricle needs to overcome in order to push blood forward into circulation. So the harder this is, and therefore the less blood is actually ejected in that beat. Therefore, the higher the afterload, the lower the stroke volume, and vice versa. The lower the afterload, the higher the stroke volume. Let me demonstrate it this way. Now, in this scenario, I'm the heart, and this bag is blood. Without afterload, I can move this bag without much effort at all. Now, if I add afterload, it takes a lot more effort and a lot more force to be able to move the bag even a little bit. So the maintenance of stroke volume is carried out by a constant interplay between these three forces. And that's it. That's stroke volume. All done. Easy peasy. Let's wrap that up in a bow and we'll move on. Okay, so let's move on to heart rate. So it seems pretty self-explanatory, but it's pretty important to define heart rate as the number of times the heart will beat in a single minute. And it's also pretty important to understand how this is controlled. So heart rate is basically controlled by the autonomic nervous system. The parasympathetic nervous system, the system that slows everything down and allows us to rest and digest, pretty much has all of its control of the heart at the SA and AV node. So it predominantly affects heart rate. And a little fun fact is that the inherent firing rate of the SA node is actually at 100 beats per minute. So for us to maintain our normal resting heart rate of sort of that 60 to 80 beats per minute, that is sort of normal for an adult, we have a constant parasympathetic tone on the heart and on the SA node. And that sort of keeps it under control at that sort of 60 to 80 beats per minute. Little fun fact. The sympathetic nervous system, while it does control or does innervate the myocardium, it also innervates the SA and AV nodes. So when the sympathetic nervous system is stimulated, we'll have an increase in heart rate and it'll get us past that 100 beats per minute mark. So understanding this will help us understand the fact that anything that innervates the sympathetic nervous system is going to cause an increase in heart rate. So whether that's exercise, stress, certain kinds of drugs, but also things that inhibit the parasympathetic nervous system like certain drugs do, will also cause a bit of a tachycardia or a bit of a high heart rate. Conversely, anything that stimulates the parasympathetic nervous system is going to cause a bradycardia or a slow heart rate. And that's it. That's really all we need to know about heart rate at this stage with the hemodynamic formulas. So let's move on to cardiac output then. Cardiac output is heart rate multiplied by stroke volume. And if we remember that heart rate is beats per minute and stroke volume is volume per beat or mils per beat, we cancel out the beats and we end up with mils or volume per minute. So essentially cardiac output is the total amount of volume that is pumped through the heart in a single minute. Another way of saying this is it's the total amount of blood circulating through my entire body in a minute. Another word for this is blood flow. Awesome work, guys. We're halfway there. One formula done. one formula to go. Let's get into it. So before I jump into the blood pressure formula, I'd like to discuss a couple of things about how we can build pressure within a system that has fluid running through it. So if I have fluid running through a system and there is absolutely no opposition to the flow of that fluid, right? I'm not going to have any pressure within that system. In order for me to build pressure, I need to impose some sort of opposition to that flow. I need to create resistance to that flow, okay? And as soon as there's resistance, there is pressure. And the more you increase that resistance, the more pressure you can build. There are three things that can introduce resistance into a system like this. One thing is the viscosity of the fluid. If we increase the viscosity of the fluid, it's more difficult to push that fluid through the system, and therefore it will build resistance to flow and increase the pressure within that system. The second thing is the length of the actual tube that the fluid is flowing through. So the longer the tube, the more resistance there is on the fluid, which means the more pressure is required to push fluid through that tube. Finally, and the most important one for us today, is the diameter of the tube. So the smaller the diameter of the tube, the more resistance there is to the fluid flowing through it, and therefore the more pressure there is in that system. Okay? A good example of this is water running through a hose. Okay? Now, while there is some friction from the hose on the water as it's running through, it's a relatively low pressure system, as you can see here. But as soon as I put my thumb over the end of the hose, I'm resisting the flow of that water out of the hose, and bang, increase in pressure. Okay, so let's bring all of this back to hemodynamics. So why is it important for us to have pressure in our body, in our circulatory system? It's super important. We need that minimum amount of pressure to ensure that every capillary bed in every organ between my heart and the tips of my fingers and the tips of my toes receive blood. But more importantly, we need to be able to have enough pressure to push against gravity so that we can ensure that my brain receives an adequate amount of blood. And why is that important? Blood carries the good stuff, right? It carries oxygen, it carries glucose, it carries the fuel that's required for us to meet metabolic demand. But also we need to have enough pressure to bring that blood back and carry all the bad stuff, the carbon dioxide, the lactic acid, and all those byproducts to areas where they can be excreted, like the lungs and the kidneys and that kind of thing. So maintaining an adequate amount of pressure is exceptionally important, and it's important for us to understand. So how do we build pressure? So the formula says blood pressure equals cardiac output times peripheral vascular resistance. Well, we've defined cardiac output. Let's look at peripheral vascular resistance. Well, peripheral vascular resistance, by definition, is the body's ability to create that resistance, to create that opposition to flow in the peripheries of my system. So we're talking about, my skin, non-vital organs, that kind of thing. So how do we do that? Well, we're pretty limited in the way that we can actually increase or decrease the resistance within our body. We can't change the viscosity of our blood, not really. There are certain conditions whereby people have, slightly more viscous blood or less viscous blood, but they're not things that will help us control hemodynamics. There's more conditions where those people have to deal with it, and we may touch on those in future videos. The same sort of applies for the length of our blood vessels, right? That's pretty constant once we're adults. We can't increase the length or decrease the length of our blood vessels, so we can't really control resistance in that way. A little fun fact here though is that that rule explains why children can tolerate much lower blood pressures. The younger they are, the shorter their vasculature, and therefore the lower amount of pressure is required to move blood through their system. Finally, we come to diameter. Now this is where we can more finely control our hemodynamics in terms of our vasculature. As blood flows through a blood vessel, something really interesting happens. If we take a closer look, we could actually see that the blood that flows through the middle of the blood vessel is actually going at a slightly faster rate than all of the blood that's flowing along the blood vessel wall. The reason for this is all of that blood that's around the blood vessel wall, that's adjacent to the blood vessel wall, is experiencing a ton of friction, which is an opposition to flow, that's being placed on the fluid by the actual cells of the wall. Whereas the stuff that's going through the middle of it is almost going by completely frictionless with almost no opposition. So what can we understand from this? Well, if I keep blood flow constant and I constrict that blood vessel, if I make the diameter of that blood vessel smaller, I'm going to be exposing a lot more of that blood to that resistive force of friction. There's going to be a greater proportion of blood being restricted. And what that's going to do is it's going to raise my resistance, which is then going to raise my pressure. Conversely, if I dilate that blood vessel, if I make it larger, I'm allowing a lot more proportion of blood to pass through almost unrestricted. What that's doing is it's reducing the resistance, which is then reducing blood pressure. Both divisions of the autonomic nervous system play a role in blood vessel diameter. The sympathetic nervous system will cause the blood vessels to constrict, whereas the parasympathetic nervous system will cause blood vessels to dilate. Whew, that was a lot of information. Nice work for sticking around. But let's have a quick look at how all of this comes together now. As I mentioned earlier, maintaining that blood pressure is so important for ensuring that all of my organs, particularly my brain, is receiving an adequate amount of blood, which means an adequate amount of oxygen and glucose to fuel metabolic demand. So the body has built-in mechanisms that will affect one or more aspects of these formulas to try its best to maintain that blood pressure. How's this? You ever stood up too quickly from being seated for a long period of time? When you stand up really quickly, gravity makes the blood that's in your system sort of pull down towards your legs. And what that means is we have less blood returning to our heart in that moment, which means we have a reduction in preload, right? And reduction in preload means a reduction in stroke volume. A reduction in stroke volume will have the knock-on effect of reducing my cardiac output, and that will then reduce blood pressure. So with that reduction in blood pressure, my brain isn't getting enough blood. So what happens? I get a little bit lightheaded, a little bit unsteady on my feet. So what does the body do to change that? It will increase my heart rate. It will cause the blood vessels in my legs and that kind of thing to constrict. It'll push blood back to my heart, which will increase my preload. It'll cause my heart to pump a little bit harder, which will increase contractility, and it will increase my blood pressure. Okay, let's apply these formulas to the emergency setting though. So say I have a patient who's had a reduction in stroke volume for some reason. Maybe they've had a catastrophic external hemorrhage, which has resulted in a reduced blood volume, which means I have a reduced preload and a reduced stroke volume. Or I have a patient who has experienced a myocardial infarction that has resulted in an inability for the heart to contract with enough force to push adequate amount of blood out. What this means is that reduction in stroke volume is going to cause a reduction in my cardiac output. But what I might see in this patient is an increase in their heart rate to try to compensate for that reduction in stroke volume. This will actually maintain a normal blood pressure because I've increased my heart rate to maintain a normal cardiac output. Similarly, if I have a patient for some reason who has no problem with their stroke volume but has suddenly had a massive drop in their heart rate, well, what this will mean is that while stroke volume per beat is enough, my heart rate has gone too low to maintain an adequate amount of blood flow, which will reduce my blood pressure. So what my heart might do is constrict with more force, or the body might tell my blood vessels to squeeze a bit tighter to increase my resistance, or to push more blood back to my heart to increase my preload. Now, all of this is done to maintain cardiac output so that we can maintain blood pressure. But if for whatever reason we are unable to maintain an adequate cardiac output, an adequate amount of blood flow, the body's last ditch effort is to try to squeeze our blood vessels as tight as possible to try to increase the resistance in our peripheries as much as possible. And remember, an increase in resistance is going to try to increase pressure. But if I have a reduced flow, increasing that resistance is going to try to maintain a normal pressure. Okay, so let's try to put these formulas into practice a little bit more with those scenarios that I introduced at the start of the video. So the first scenario was that 55-year-old male with chest pain who presents diaphoretic and extremely pale as we enter the room, right? We haven't even asked a question yet. Walking onto a scene and seeing a patient who's unnaturally pale and sweaty as they're at rest sitting on a chair should always ring alarm bells, right? This is an unwell patient. But let's think about why. Generally, when someone's presenting unnaturally pale, it should be telling us that blood is being shunted away from their skin towards their core. And we can make a connection here with our formulas. In order for blood to be shunted away from the skin, there has to be widespread vasoconstriction. And we know that vasoconstriction means a reduction in the diameter of the blood vessels, which means an increased amount of opposition. We know that this is a naturally protective mechanism to a sudden reduction in cardiac output or blood flow. So that's the first connection we need to make. Going on from there, the fact that he's diaphoretic should be telling us something. The sympathetic nervous system is responsible for sweating. So if someone is diaphoretic, their sympathetic nervous system is in overdrive. So going back to our discussion, we know that the sympathetic nervous system is also responsible for widespread vasoconstriction, which will increase peripheral vascular resistance, but will also increase the amount of blood flowing back to the heart, increasing preload. It'll also increase contractility, both of which will increase stroke volume. And we also have the ability to increase the heart rate, which will also help to increase cardiac output. So what is all of this telling us about our patient? Well, keep in mind that we haven't asked a single question yet, and we haven't got a single vital sign yet. But the information that we do have is that we were dispatched to cardiac sounding chest pain, and we have a patient who looks like he's in hemodynamic compromise. While it's important not to make brash judgments on very little information, what this should be doing for us is getting our spidey senses up a little bit, making us act with a little bit of urgency. Because if we put these things together, we have a patient here who may be having a significant myocardial infarction that is compromising the heart's ability to pump adequately, which is making all of these other systems come into play. So with that extra piece of information and understanding, what we might do is we might treat this patient with a little bit more pep in our step. We might start initiating treatments a little bit quicker than we would have normally. Or we might consider extricating to the ambulance and moving towards a hospital a little bit quicker than we would have if we didn't make those connections and we waited to get an ECG, for example. So it's quite important to include this concept into all aspects of your management and gathering of information. Now let's move on to our second patient. This is a 30-year-old male who's received a slashing injury to his femoral artery, which has caused a catastrophic bleed. Now, we already know that his hemodynamics are compromised. He's lost a lot of blood, which means his volume depleted, which means his preload has been affected, stroke volume, cardiac output, and blood pressure, all affected. But we've stopped that bleed. Maybe we've hung a bag of fluid up and we're transporting to hospital. What we're seeing with this patient is a change in vital sign that is pretty important to us. His heart rate has gone from 100 beats per minute to 140 beats per minute. What's that telling us? It should be telling us that he's deteriorating. Something is causing his stroke volume to further decrease, which is causing his heart rate to climb to try to maintain cardiac output. So what do? This should trigger us to do another assessment of him, pull the covers off, have another look at the site of the injury, see if it's continued to bleed, if our hemostatic measures are failing. If they are failing, we can address it. If not, we can look for another injury somewhere that maybe we've missed. So really important to apply these formulas in all aspects of your job, not just when you're doing a heart rate and blood pressure, but right at the start of the job, as we saw with patient number 1, and on reassessment of the patient, as we saw in patient 2. Okay, that's it from me today. Thanks very much for watching. I hope this video has been helpful. It is a very difficult topic once you're starting to study it, but just like anything else, practice makes perfect. The more you try to apply these formulas to your case studies, to actual patients that you see, the more familiar you'll get with them, and the more it becomes like second nature. So I really urge you to think about these formulas when you're looking at vital signs, when you're thinking about patient presentations and patient deteriorations and that kind of thing. And I promise you, it'll become familiar. If you've liked this video, please give it a thumbs up. I've got plans for a ton more videos coming, so please subscribe and keep up to date with everything. And please feel free to leave a comment below. I'd love to know what you guys thought about the video, whether there's something I could do better, any topics that you'd like me to cover. I'm open to hearing all of it. So thanks again for your time, guys, and I'll see you next time.